Okay, I'm going to get started. The big thing here today that I wanted to kind of focus on was going over STD rates. We've increased in STD rates nationally and in the state of Maine. And with that increase, I thought it was a good time to kind of check in and go over those numbers, and then to kind of emphasize some testing information as well as extragenital testing and numbers around that as well. And then we'll talk a little bit about the treatment guidelines, and then we'll kind of wrap up very quickly with some pre-exposure prophylaxis information. If anyone was interested, we could talk about separately afterwards. So to get started, I'm going to jump right in with the national numbers for chlamydia. So as we kind of go through the slides, you'll see some dips and some peaks, but for the most part, what you'll see across the board is this trend of increasing rates. So for chlamydia, looking back to 2000 all the way up until 2016, which is the most recent CDC data, they haven't compiled all of 2017 yet. We see like a really, really nice, steady, slow increase with women always testing more often positive than men. Does anyone have any idea what the actual total number of cases? What kind of shows it on the side for the rate? That's the actual number of chlamydia cases diagnosed in the U.S. in 2016. I know it's only anyone else is going to chime in as well, though. Million. So a lot of chlamydia. One of the CDC recommendations for testing is, testing sexually active women 25 and under, but really any woman that is sexually active with more than one partner that is coming in on a regular basis could be recommended for a chlamydia GC screen, by all means. In the industry, we offer self-swabbing, which is also a great option. Like if women don't necessarily like they need the whole thing, or they're not comfortable with an exam day, you can still offer them to self-swab and send out the specimen the exact same way. Actually, some research on that too, around self-collection versus provider collection, and sometimes it's even a positive rate among the self-collection. Interestingly, with self-collection, since there's just two of you, I brought two of these. You'll find we see a lot of men who have sex with men at India Street. There are anal and oral swabs, but you'll find that the anal and vaginal swabs are really easy. Oral swabs are really hard because that thing of making yourself choke is actually much harder to overcome than just like doing a quick little swab is actually pretty easy. Good question. For men having sex with women, they're like a low-risk group in terms of what the CDC is looking at. So key recommendations that are more specific to men having sex with men at all ages. So men having sex with men really of any age, getting tested for HIV at least once a year, and then more often if they have multiple partners and to multiple concurrent partners. For men having sex with women, there just isn't enough evidence to indicate that they're a high enough risk group to do that all the time. Said, at India Street, again, we kind of see a group of people that tend to self-select slightly higher risk, right? They're coming specifically to an STD clinic. And on our intake forms, we have a specific questions like how many sex partners have you had in the past 3 months, and then how many partners in the past 12 months. For men having sex with women, if they're indicating 1 or 2 partners, we might consider them low risk. But anyone that's using dating apps and is reporting 5, 10, 15, 20, upwards of 100, offering the whole shebang is always a great idea. So similar curve we're kind of looking at for Maine here. So again, like a slight dip, around 2009, 2010, but again, staying on par with the increase that we're seeing nationally. So this takes us through 2017. Does anyone have a guess of kind of where we are January to June for chlamydia in Maine? So I have reporting for the first 6 months of the year if anyone has a guess. Huh? Yeah, we won't know the total curve until the very end, but we're looking at, just over 4,500 cases at the end of last year. So yeah, any guesses where we are sort of midway through the year this year? Close. Actually, that's high. We can catch up to that at some point. We're just right around 2,000 right now. So we're actually right on mark to sort of hit almost exactly the same number. So we'll see how the rest of the year turns out. It's a little bit more of a stable curve here, and it is interesting to note that it does sort of flip in the middle here with with men testing positive more often than women. Gonorrhea, especially looking at that, like these last 2 years, this peak in men is a particular interest. So we have seen, an increase in men testing positive for gonorrhea. Part of that increase can also be an increase in like knowledge around extragenital testing, because someone could test negative in the urine, but then test positive at an anal or oral site when they do swabs. So that definitely is part of it. And again, for all men having sex with men, offering the whole kit and caboodle, again, giving you the opportunity to catch a positive that you might not catch in the urine otherwise. Recently had quite a sharp dip in 13 to 14, but again has sort of slowly been climbing again, ending at just under 600 in 2017. Does anyone have a guess for where we are January through June for this year? Anyone else? 28. June. Just to like kind of put that in perspective, that's January to June. For this time in 5 years, the 5-year median before 2018 was 135 cases for June to June. So we're already double that average rate for the preceding 5 years. I chose this graph in particular. It's primary and secondary syphilis. We're not including late syphilis in this. And I liked that it was separated out geographically, because even though we've seen a big increase in syphilis cases, Maine, actual numbers-wise, it still is significantly lower than other parts of the country that are seeing like much higher like actual numbers. So you can see that the West really dominates this graph, and they've actually had like a pretty steep increase here as well. There's a lot more congenital syphilis out west as well, which is not something that we're really seeing so much in Maine. A lot of the positives we see in Maine, again, are among men having sex with men. I thought this was a nice perspective. So the Northeast is kind of catching up here with the Midwest a little bit, with the South a little bit, and then with the Midwest, so kind of hanging out down at the bottom. Again, this graph I find really interesting, and I haven't gotten a solid explanation from CDC why it's quite so bumpy here. But we really did have syphilis pretty low for like a few years. So for like 3 to 4 years in a row, it kind of hung out around 20 in cases, and then it's just, again, been steadily climbing ever since. Does anyone have any idea where we are for 2018 for syphilis? Any guesses? At just over 80 at the end of last year. Like just right about it. We're at 46. So again, putting that in perspective with the preceding 5 years, the median 5-year was 19 cases. Again, like not huge numbers per se, but a really large increase over what we had been seeing in the past. Does anyone know what the primary, like the front line of treatment is for syphilis? Yeah, it's been the same for essentially. If someone has a penicillin allergy, it's doxycycline, and it's a pretty long course. I want to say it's like 2 to 3 weeks. Adherence with doxy, depending on the patient, can be tricky. So stock of bicillin is really important, but also keeping in mind that we do have folks with allergies, and that to go on doxy for a little while. I also wanted to emphasize for syphilis again that with Maine not necessarily having the highest numbers, but a real increase in rates. For primary and secondary syphilis in the U.S. in 2016, we were looking at about 27,000 cases. And then with congenital syphilis, about 628. But again, most of those happening out west. So national CDC is sort of reorienting themselves to take that into consideration. But again, it's not really something that we're seeing so much in Maine. HIV, Maine is a really low incidence state for HIV. There are significantly more cases of pretty much every other reportable disease other than HIV. I chose this one, though, really just to emphasize the risk groups that we're looking at here. So the top 3 risk groups you'll see are all men having sex with men. Essentially, Black men having sex with men, the highest risk, followed by Hispanic, Latino, and then white male-to-male sexual contact. With the demographics in Maine, we don't see as much of Black men having sex with men, whereas you'll see in the South, the rates of HIV are significantly higher with that demographic distribution. bearing in mind that if you have any folks that are coming in when they're doing your sexual history intake or your physical, whatever it may be, if someone's reporting male-to-male sexual contact and they haven't had a recent HIV test, that's a really great kind of like get your foot in the door to like offer that. And then in addition to say, like, you know, while we're doing that, let's just include everything since you're here, right? So HIV, syphilis, chlamydia, and gonorrhea, right? Because infections like to travel together. So someone can be positive for chlamydia, but also be positive for something else at the same time. So just to emphasize again, you know, Maine is not really a high incidence state. You'll see like the darker band down here through the south, and then in California, significantly more cases. So for Maine, this was what, in 2015, so it's a little bit more now, but we're looking at about 2,000 people living with HIV/AIDS in Maine. So again, it's on par with the Midwest being one of the lighter states on the map. This dip here, so we had a pretty significant dip from 2016 to 17, so it hovered for a really long time around the 50s, and then last year it took a pretty good dive. I think it was like 31 or 32. And does anyone guess about where we are for January to June 2018? So we're at 15 right now, which is below the 5-year median average, which is really. I'm going to talk a little bit about the extragenital testing. I have a couple of these. It's a guide to taking a sexual history intake that's provided by the CDC, and it has little tabs on the side here, the 5 Ps. So partners, practices, protection from STDs, past history of STDs, prevention of pregnancy. So, and when you're doing a sexual history intake with someone, if you're asking, you know, are you sexually active, yes or no, tell me a little bit partners, are they male, female, transgender, and going from there on to like, so what kind of sex are you having? You know, are you having oral sex, having vaginal sex, having anal sex? And then really important to know for your men having sex with men, are they both topping and bottoming? And if so, again, offering those swabs when necessary. If one's never had a full STD screening, you're kind of missing that piece, again, because folks can test positive at other sites and not be positive in the urine. So this is data from our clinic from January to December 31st of last year. You'll see for chlamydia, we had 107 total positives, and we broke them up by urine or anal. If we hadn't done the oral and anal, we would have missed about 37% of our positives, right? So that's huge. That's someone that's undiagnosed that's still having sex with, you know, more and more partners and potentially spreading chlamydia. So this is a way of heading off spread of disease, getting that person treated, and also offering expedited partner therapy. So if someone comes in and they test positive with you and a primary partner, make it possible for them to access, you know, 1 gram of azithromycin once right away. The same with gonorrhea, but you'll see with the percentage over here, it's double what it was for chlamydia. So missing 70% of positives. Right? That's really, really huge. Someone's not getting tested at all sites and they're positive. You know, it's a total missed opportunity. And with positives, especially not with chlamydia, but with gonorrhea, this is a reported condition to the state. So this will show up in the queue for one of 2 disease intervention specialists, either CME Brown or Penny Sargent. Kim Brown actually works at India Street a couple days a week and is responsible for all the coastal counties. So if someone tests positive for gonorrhea, syphilis, or HIV, that'll show up in her state like system too. That person will get a phone call just to follow up with them, you know, make sure that they were tested properly, that they got treatment. If they didn't and they'd like to come into India Street, we will treat them for free. And then on site, Kim will offer partner services. So essentially that's like, hey, you tested positive, would you like to notify your partners? If you don't, would you mind I notify them, right? And that's a call, basically like, my name is Kim, I'm calling from the CDC. One of your partners recently tested positive, can I offer you a free screening? You don't mention the person's name, it's just an opportunity to get that person in the door. So if you have a positive and that's happening, that person is being offered partner services at some point by Kim or me. National numbers for the National Alliance of State and Territorial AIDS Directors, kind of looking at the same thing. So pharyngeal and rectal gonorrhea, and then just rectal chlamydia. But again, much higher numbers even than ours. If they hadn't done the extragenital screening, the percentage of positives that you would be missing. So again, really kind of over the a little bit driving it home, but again, like offering your extragenital screening absolutely when you can. Moving on to PrEP. Has everyone here heard of PrEP? Yeah? Yes? Great. So we've been offering pre-exposure prophylaxis at India Street since October. We have about 50 patients that are on it right now. Most of the folks that we see that come to us that want to get on PrEP have kind of heard about us through word of mouth. We don't do a lot of advertising. PrEP is a great intervention strategy for someone, especially there's a talk about this concept that if someone is taking PrEP, they're just going to stop using condoms altogether. And what we have seen is that most folks that are already using condoms intermittently just continue to use condoms intermittently. The PrEP doesn't change that behavior. Very few people, and this is probably reflected as well, how many people have met someone that reports 100% condom use all the time? Yeah, not many, right? You get people reporting either no condom use at all or like people somewhere in the middle, right? So PrEP is like another strategy that goes along with using condoms sometimes. I like this series of posters specifically that emphasizes like the daily regimen aspect of it, so getting folks used to taking a pill every day, right? So it's kind of like the birth control HIV. Someone who's not used to taking a pill at the same time every day can kind of get used to this idea of having like a schedule, like taking it with breakfast every day, taking it when you brush your teeth, taking it at night when you go to bed. So making it a part of someone's daily ritual is a really great way to kind of easier for uptake and adherence. Adherence is key, again, just like birth control, so taking it at about the same time every day is huge. I brought a little summary of all the studies that were done for PrEP efficacy trials. The more adherent someone is, the better level of protection that they have. And what the studies have found is when they test people, they test their blood to look at drugs in the system, you're over 90% effective at preventing HIV. There have been a couple of folks that have tested positive for HIV while on PrEP. I think the last one was in Canada, and it was found to be like a highly virulent strain of HIV. He had been very adherent to his PrEP. Prophylaxis does have like a little bit of a hand-holding process at the beginning. There's a little bit of lab work that goes along with it. So collecting, a complete metabolic panel, doing chronic hepatitis panel to check for someone's Hep B status, get going. You see them 1 month to kind of close the window on HIV, and then from there on out, you see them every 3 months. So it's getting used to, again, seeing your provider a little bit more often. I can't emphasize enough here that if someone is on Truvada as PrEP with you, that any prescriptions are only ever for 90 tablets at a time. We have seen in the past that folks that come to us have been on Truvada as PrEP for a year, and they haven't had an HIV test because their provider wrote a script for 12 months. I also highly recommend the Main Med Specialty Pharmacy and Apothecary by Design, which I know used to be a neighbor of you guys downstairs. They won't fill prescriptions longer than that because they're very familiar with Truvada as PrEP, whereas a more robust pharmacy like a Walmart or a CVS isn't necessarily going to catch a Truvada as PrEP prescription being a little off if it's longer for 3 months. So they're also great with all the financial assistance that goes along with it. Truvada, as you can imagine from Gilead, is pretty expensive out of pocket. I think it's a couple $1,000s if you were going to pay for it every month. Gilead have like a really good financial assistance program. So if someone doesn't have insurance and make less than about $60,000, I believe it is, they almost always get approved for free meds. And then what someone is looking at really otherwise is just getting their testing taken care of. If someone does have insurance, copay is high. Gilead also has a copay card. I would say amongst our folks at the clinic, we almost never see anyone paying anything to get their meds, which is really great. Kind of skip a bit ahead here, but populations that can take PrEP. Again, we mostly see men having sex with men, but there are other folks that can do this. So if you have a heterosexual serodiscordant partner and they're trying to get pregnant, PrEP indicated for that. It's fine to use that with pregnancy. Folks who are injecting drugs, there are a couple studies, one out of Thailand showing some efficacy for folks who inject sexers. And this last one is kind of like a foot in the door conversation. If you have a patient that's tested positive for chlamydia, gonorrhea, syphilis, or maybe has an HIV positive partner that is virally suppressed or using condoms, so again, a great way to say, hey, have you heard about PrEP? Yes, like, do you want to talk about it? Do you have any questions? Doesn't have to be prescribed that day, but just opening the door to that conversation, letting that person know that if it's something that they want to access here, that they can. And then too, just because it's nice, there are lots of resources here in Maine and in this building. Keena Thacker, one of the providers here, also comes over sometimes to India Street as well. But if you are looking for like a clinician consultation line, I think this one is sponsored by University of California, San Francisco. And so they have a line that folks can call to get a little bit more information. And they'll say, you know, CDC, again, has tons of provider information as well for stuff like this. There is a list of ICD-10 codes that go along with this. Some of them can be a little bit stigmatizing, as you can imagine. High-risk homosexual behavior is not like a great ICD-10 code to have to use for someone. For labs, when we send them in, like a CMP or a chronic hep panel, we tend to use the 79.899, which is other long-term drug therapy, so less stigmatizing than some of the other ones that are out there. Kind of circling back here to talk a little bit about treatment. Every now and again, we get folks that have been contacted by Kim or Penny, and they haven't always received the correct treatment. This happens a lot with gonorrhea, unfortunately. Does anyone know the treatment for gonorrhea? Nope. Naloxone and a gram of azithromycin. So some people look at folks that got one or the other, but not both, and they really need to have both at the same time. So the most recent treatment guidelines from the CDC are 2015. So I've left a couple of booklets here. They have little tabs. They're pretty great. But just so you know, there is also an app for that. And I will say our medical director, Dr. DiMatteo, does actually use this, and we have this up at the clinic. Especially if someone has an allergy, it gives you the alternatives for treatment, which is really useful. We did have someone that had an allergy, and we had to run to the main med specialty pharmacy to pick it up and bring it back and administer it. So having something like that on hand can be pretty useful. I know really fast. I know your time is short, so I wanted to do that quickly. Are there any questions about any of that?
I'm a health psychiatrist, but I definitely have some patients who are interested in PrEP before going off to college.
Okay.
And how comfortable are the college health services in continuing? Because oftentimes they can't be back for 3 months.
Yeah.
They're back in, you know, they leave in August, they're back in December, back in May.
Mm-hmm.
In terms of every 3 months, how good are college health services about being able to continue PrEP?
It depends on the college. Yeah, there are definitely some here in Maine that do it, and they're very comfortable with it, and they just make a plan for over the summer. And then there are other colleges that don't do it at all. They're not robust enough. So if you have someone that's really interested and you know which university or college they're going to, I would call them directly, and I would find out what they can do. The really big thing is that if you're starting them and you can get the CMP and the chronic hep panel to get going, that's really the biggest part of it. And then as long as they can get an HIV test every 3 months, that's like your absolute bare minimum. Imagine that most colleges at least can offer STD screening as well. And if they can't, if there's like a Planned Parenthood or an equivalent facility around, that would be like a supplement for a student to go and do that. And with them making probably little to no money on a Planned Parenthood kind of sliding scale, they may not even pay anything for their STD testing. Yeah.
So if you can arrange the testing,
yeah. Yeah, it's like if someone is in Pennsylvania and goes to a Planned Parenthood, but they sign a release and can fax you HIV negative so that you have that on record for yourself, that's absolutely fine. Yeah. We have patients that come to us for STD screening but get their PrEP from their primary care, and we just fax over their results every 3 months. Yeah.
Are you offering PrEP?
Are. Yeah, there are, definitely. Yeah.
Some of the FDA-based trials, there was some trials that only said it was 42%.
Yeah, it depends population and depends on the adherence. It also depends on the presentation. So there were like some badge rings and other things that were tried, but Truvada as like an oral daily tablet, if you're taking it every day, it's over 90%. Uh-huh. Yeah. 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 I mean, it's a good, yeah, it's a, yeah. It's a good summary of the studies that were done. If you go into them individually, if you're inclined to read all of these, you'll find always like a little breakdown, like then the number that they tested their blood to look at drug levels, and anyone that had a significantly high drug level also like showed the equivalent adherence with it. Right, so lots of times people will be like, yeah, I took it every day. That's what they're self-reporting. Then you test their blood, and it's like, no, they probably weren't taking it every day. Yeah.
Is there a way you're going to get it off to an O and like anal, or can you do one versus together? Like is the oral going to give you a better result than both?
Well, do more is not what's going to give you a better result. It's more what kind of sex is that person having. Right. If having insertive and they're also performing oral sex, then you should just be testing both because those are both points of contact. If someone's not reporting oral sex, then by all means don't waste a swab. But if someone is reporting points of contact in all of sex, then it's worth doing all of them. Oral and rectal are the same swab, and then we have a different type of swab for vaginal swabs. It might be different depending on who you purchase them from, but it is good to know which swabs to use because it's happened that sometimes the wrong swab gets used and it gets kicked back to you, and then you have to ask your patient to come in for another butt swab, which depends on how you feel about it, I guess. But yeah.
Is there might be more questions for the no, I have a patient that recurrent GC community. I have one prep. I guess does she or look at I mean, I just not worried about, but prep.
Yeah. Chlamydia and gonorrhea. Yeah. That's great.
Yeah, but and no, I just I just worry about it. And travel too.
Yeah. It probably is, and I printed off an article that we give out in clinic to our residents that come through, with 5 reasons why STDs are sort of back in business. And one of them is dating apps, right? And just the ability of geolocating to put sexual partners in touch that that would otherwise not have been in touch with one another. And so for someone who is recurrently testing positive, how many in a 3 to 6 month window?
I asked the number
Yeah. Okay. Yeah. Kind of from a harm reduction approach, it could be more of a, every time you come in, I do see that we're getting back some positives for chlamydia and gonorrhea. Awesome, why that's happening, and kind of opening the door maybe more for that patient to talk about why they think they're testing positive. And some good harm reduction strategies can be, instead of you need to use condoms all the time, it could be going to this one specific sex party that's out of state, in a state that has a higher incidence, how would you feel about using condoms for that party? Sort of starting with some small behavior change steps, but also assessing their willingness and readiness to try something like that. And then the next time they come in, kind of asking them, so how did that go? Did that work for you? And it worked for them? Trying another conversation around that. Yeah, it'd be hard too for people that test positive often if they're in a pool of sexually active partners that also are in touch with other pools, right? You can imagine that map of multiple partnerships. That can just be really, really difficult. And the fact that that person is coming regularly to talk to you and get tested might be the most that they're able to offer now. Yeah, that's wonderful. Yeah. Yeah. I mean, I will say the fact that someone is willing to talk about their sex life already with the primary care is really huge, because we see that barrier a lot where people feel no, I can't talk to my primary care doc about that. That's why I come here. In that environment where you're asking people not just, are you having sex, yes or no, but it's tell me more about the kind of sex that you're having. And surprisingly, you find that some people are very candid about their sex lives, maybe too candid. You might learn some things. But again, open that door where someone feels okay, if I do have a question about a discharge or an itch or a bump, that this is a good place that they can do that. Question: self-swab posters. Has anyone else had patients self-swab? No. These are great. We keep them in the clinic. They were developed by the University of Washington at the Northwest AIDS Education Training Center. And for people who haven't done it before but that do get swabbed regularly, it's a nice thing to be able to offer them and kind of let them, give it a try. Questions about anything else? Yeah, it can use event-based. It's not approved for that by the FDA in the USA, but it is used in other places, and it could certainly be used that way on the black market. Take 2 pills before an event, a pill day of, and a pill after, I believe, for a total of 4. But you'll see a lot of the studies is that 4 is kind of like the magic number for conferring a fairly high level of protection. So what studies that have looked at that have found is that if someone is going to a sex party every weekend, they're taking 4 a week. Like they're really close to being re-adherent. So it's harder to really assess if someone just goes to a sex party like once every 6 months doing the same thing. So it gets a little bit tricky. But yeah, it's not approved for that in the U.S. It is only daily. Interesting though. Anything else? Thanks for coming, guys. Appreciate it.
Any questions from Yarmouth or FOTA?
Does anyone have any other questions about PrEP? I do have like a couple PrEP-specific handouts.
I think you might class me because that was,
Ooh, I might. Yeah, definitely.
it was very eye-opening. I hadn't heard about it before you came. This is another of it, and he complimented me for lecturing on it.
Good. Yeah, it's nice. I think it's definitely the word is spreading, which is really nice. And I wouldn't know for sure right now if the dip that we're seeing in HIV could be partly attributed to PrEP. It would certainly be nice if it was. But even just the idea that more practices are, openly and comfortably talking about people's sexual practices is also huge.
Right.
Yeah.
Thank you.
Absolutely.